Good morning, everybody. Nice to see all you folks here. Merry Christmas, I guess, is appropriate for many of us. Good morning, Dr. Rivera.
Good morning, Dr. Snell.
How are you, sir?
I'm doing well. How are you?
Quite well, thank you. I believe you were married recently, were you not?
I was beginning of September. I did get married.
Congratulations, sir.
Thank you so much.
And Dr. Mark Heller is joining us as well. Good morning, Mark. And hello out there in Facebook world. For the uninitiated, this is Facebook Live. Most of the folks that are joining us over here are not members of the NeuroCentric Approach Online Academy, which gets you the access via Zoom to hang out with me over here and get your questions answered a little more consistently, efficiently, or whatever. It's kind of hard for me to make it happen over here over the shoulder. Let's see. In terms of news regarding NeuroCentric Approach, we are coming to an end of the open lifetime membership that is currently open. It will never be cheaper than it is right now. So if you're on the fence, this would be a good time to take advantage of it. For those of you that are over on Facebook, there should be a link available to you right there for the NeuroCentric Approach Online Academy. Let's see. Chill my notifications there. We have other interesting news as well. Probably the biggest is our first course in a while, in-person course. I just firmed up the dates with former R2P head for the UWS chapter, Dr. Kelly Henry. And she and Carly Causey occupy a space in Seattle, down near the viaduct, near the Kingdom. And we have firmed up a date there for February 10 and 11, coming up in just a little bit. So those of you in the Northwest, it seems like Seattle was leading the list of for folks that were interested in getting a course in. We haven't yet decided whether it'll be an upper quarter or lower quarter, but you guys on the membership side of things have input there as well. Just let me know what you would prefer and we'll make that happen. Let's see, other things. I started putting together something that's a little bit of a short hybrid. I'm calling them, pardon the quirkiness of it, but I'm calling them nerve snacks. They're short little courses. I found an interesting product called the Leap, LEAP, that is integrated with the Thinkific platform that I have the online Thinkific or the online NeuroCentric Approach site out for. And they're integrated with them. Apparently the Leap grew out of a TikTok channel, and they allow you to be able to put together very tidy little mini courses that could be like 15-20 minutes long, and they work well off of a phone in a sort of handheld environment, and allows you to be able to put video on there and quizzes and make it more like a learning material thing. So I'm putting it on there for the specifically for the most common presentations that, or the most commonly searched for terms or nerves on our sites. So trying to appeal to the market there. I will make those available as well to members for free, but they're going to be like a very low cost way for folks like you guys over on Facebook that haven't seen, or wondering what the hell it is that we're doing with this neurocentric approach stuff. And it'll give you a little more of a hands-on feel for it. So, new course coming up. That's exciting. Other things in my own world right now that are exciting. We're going to be shifting some things around at Kabuki, and my office is moving there, so I get a little bit more space for my office. I'm excited about that. My son is coming home. That makes me about as happy as I managed to get these days in my crusty ass old age. But he is coming home from med school and arrives late tomorrow night. We'll be here for about a week. So who knows? I might get him to guest host next week's meeting here. So let's see. Before I get started with our case study today, do you guys over here on Zoom World have any comments, questions, or anything of the sort? RJ, have you been playing with this stuff in clinic?
100% I've been playing with it in clinic, but I don't have any questions right now. I've found the whole use of the system very, very beneficial in patient care.
Yeah, it kind of streamlines a lot of the stuff. I know in R2P world, you guys get exposed to a lot beyond the curriculum at school. You guys get exposed to a lot of tidbits of a lot of different systems and such. And I find, it is my intent for the, I'm just realizing I don't have the rewatch on here. It's my intent to make that a better way or a streamlined way of making that information available to you and usable without getting lost in the mix. Okie doke. I see. Oh, hi, Anna. Nice to see you again. Let's get to it, shall we? Today's case study is from someone that I have seen now a couple of times in clinic. And it was a tidy enough case that I actually wrote it up much more like a formal case study for presentation. And the reason for that is we're using manual therapy to address superior cluneal neuralgia, but there really isn't much in the way of case reports, case studies, or any kind of research on manual methodology for that. Most of the research that has been put out there regarding cluneal neuralgia, cluneal neuropathy, cluneal neuritis, cluneal entrapment, all of these various words that we use for this have been, what's been conspicuously absent is a description for how to deal with it manually. And of course, we go through that quite a bit in the cluneal nerve course that's on the online academy. The methodology that we're mostly using with that is dermal traction method, since those nerves are as superficial as they are. And I commonly find that in that area, both a combination of horse biting, handholds, and cupping in that area, dynamic cupping, put a little lube on, put one of the big massage cups on the low back and work it back and forth. Seems to be helpful with these folks. But for this particular individual, this person was referred to me by a physician that I had seen recently. And it's fun to see how these things go over the years. One of my best friends now, I got to know in my first year of practice 20 years ago. He's now the head of one of the hospitals. He's a clinical management officer, clinical medical officer at one of the big hospitals in Portland. And I got to know him in my very first year of practice because I was soliciting, if you will, to local physicians for evidence-based chiropractic. And that was an unusual thing to be spoken of in 2002 when I came out of the gate. And in fact, I think Sackett didn't coin that term until like 1995, if memory serves. But that particular doc, he was the head of a family practice residency program here in Portland. And over the years, I've enjoyed a lot of referrals from that particular clinic. Subsequently, I've seen him, I've seen his entire family, I've seen most of the other supervising clinicians there and all of their family. And every year they get a new crop of residents in, and they get taught proper appropriate referral to chiropractors. And I'm on the very short list there. It's also how I got to meet Rick Deo and co-present with him to the residents there. Rick's, many of you know that Dr. Deo is probably one of the most prolific researchers in low back pain, well over 400 peer-reviewed papers to his name. So that was kind of a hoot to be able to co-present with him. But in that residency, in one of those residency classes, happened to be a physician who now is in urgent care in Portland. And he presented to me 6 months or so ago with some ongoing low back pain after disc herniation in his previous, in his earlier life. And most of his pain turned out to be cluneal neuralgia. And this was a novel thing to him. So he's now banging the drum and learning more about this. And I'm trying to talk him into getting better with needles so that I've got some place to refer to when things don't work well with the manual approach, because they don't always. But a recent referral from him was our case study today. So this particular individual is a 61-year-old female who is a data management expert, actually works with one of the major EMR companies. And she presented with a history of 20 years of intermittent back pain, which began postpartum lifting injury with her child. She was diagnosed at that time with a lumbar disc extrusion and right leg radiculopathy. She received an epidural steroid injection, and that helped with the original issue. She then, with subsequent episodes, had responded well to oral steroids, Medropax, and so forth. But she had been plagued with that for a number of years, had seen physical therapy, had some success using McKenzie-based therapies. But now at 61, 20 years into this, as I have coached you guys, especially through the Fix Your Own Back program, After that disc injury, the pattern of the injury changes over time. The disc gristles up. There is less of a, we'll call it a hydraulic effect in the disc. So that helps to explain how we can get some evidence that suggests that McKenzie type end range loading can cause nuclear migration, and in others it doesn't, because those papers to date have not factored in an aging disc and what happens to it over time. But that evidence is there, is out there. It's just not been applied in that McKenzie dynamic. So as that material stiffens and the body heals that area, then the intense insult to the nerve root backs off over time. Now, what persists? Well, often the elasticity of the neural tract will be somewhat compromised owing to what we will see of an infiltration of connective tissue with the inflammatory response in the affected nerve. So the elastic modulus of the neural tract can be affected and persist over time, even after the mechanical sensitivity of the neural tract is reduced. In this particular patient, they also reported, though, that their symptoms had started to change and become more notable in the buttock. Although she still had some symptoms with prolonged sitting that were down as far as the posterior thigh to the knee, nothing below the knee. So the symptoms in her butt were severe enough that in mid-2022, she presented to an orthopedist who decided to take a picture of her hip. They took an x-ray of her hip and showed marked osteoarthritis. And it was proposed to her that she have a total hip replacement. And she did. So now we have a patient with a prior history of lumbar disc herniation who now has had a full hip replacement, which improved some of the symptoms in her hip, but they did not go away. So she's a year out from that, and now a previously very active individual who very much likes to downhill ski is looking at a winter in which the pain from her hip is going to keep her from being able to do the things that she most enjoys for recreation. Those things have also helped to keep her physically active enough to reduce her, to keep her physically healthy. In the interim, she's gained 10 pounds and she's now hypertensive. So we have a patient with disc herniation, a somewhat effective hip replacement, and then now she is overweight, depressed, and hypertensive. To my mind, partly because there was still a diagnosis on the table that had been unexplored. So in our examination of this particular individual, she reported that she had, I believe, a 7 out of 10 average daily pain that got worse up to a 9 with prolonged sitting. So she rarely sat. She would only sit when she had to. She was able to reproduce her pain in the office by merely sitting very upright in her chair and leaning backwards. So the physical contact of her back against the chair was noxious and caused her pain. And she was visibly squirming in her chair to try to get away from it, but she habitually returned to a very upright, erect sitting posture. On the physical exam, she showed me relatively normal range of motion. Her hip had come along quite nicely. She had a squat rise all the way to half squat depth. Her perception of her hip surgery, by the way, was that it was wonderful, that it took away most of the pain in her hip. So it's entirely possible that, we're looking at just comorbidities that are only tangentially related or unrelated at all. Doesn't really matter. So I'm not going to roll up on this and be intellectually dishonest and suggest that, the entire issue that's going on with her was because of some, vague diagnosis that only I can see and only I can treat, right? That makes me a pointy-headed Cairo, doesn't it? Her motor examination, as you guys from the Fix Your Own Back program and from our contacts here will note, we do by doing repetitive single leg toe stands and heel stands. She was actually subjectively, not objectively, worse on L5 and S1 myotome on the unaffected left leg. That was interesting. On the, she was negative for the seated compression test for discogenic pain. When I performed the slump test, we were able to reproduce the very infrequent symptoms that she was having in the posterior thigh to the knee. Okay. So the slump test was positive for reproduction of her symptoms, of her radiating symptoms into the leg. And those symptoms changed with neck movement and with ankle movement. So that suggested to me that the sciatic nerve tract is still involved in some way and opened the possibility that what she's experiencing now in terms of her buttock pain is actually continued sciatica. I don't know. Won't know until we get there. Similar findings on straight leg raise. The single leg sit to stand was WNL. Femoral nerve tension test was WNL. Laslik cluster for SI involvement was -5/5. When I put her into extension to test end range, repetitive end range extension per McKenzie protocols, she had no benefit from that at all. Indeed, that markedly worsened her symptoms in her butt and in her leg, all the way to the knee. So we had no joy on Extensionville. So I now do not see an active disc bulging component that is to blame for the observed radiation into her thigh to the knee. But I have some apparent irritation of the neural tract. So I'm now leaning towards an idea that that sciatic tract is still sensitive from the original extrusion, and or there's been a change in the local environment with possibly some, as you guys know, once the disc is injured, especially if there's an extrusion, then you'll have a reduction in disc space, which we see on X-ray. And that means the facet joints bear more weight. So the facet joint's bigger over time, borrow a Dr. Seuss term. And we get some now facet arthropathy potentially encroaching on the neural foramina. And then sometimes the posterior longitudinal ligament will get involved in that as well. And now we've got this lovely disc osteophyte complex that can become involved there. And in our older patients, this will often turn into a stenotic pattern that's extension intolerant over time. And on questioning, indeed, even though she didn't mention it before, she is finding that she's having some leg symptoms with prolonged walking. Okey-doke. So I'm feeling, relatively good about that. But when I go in and I palpate the sciatic nerve in the buttock and palpate the sciatic nerve in the thigh, it is definitely more tender on the involved right side, but not on the unaffected side than the unaffected side. But I don't reproduce the primary pain that she feels when she sits for a prolonged time. So when we've got a worsening of buttock pain and thigh pain with the prone press-ups, remember that we've got a laundry list of things that could be involved there. And the SI joint is one of them. We've ruled that out with the Laslik cluster. The facet joints are up there and they're in play based on the things that I've already talked about, but the cluneal nerves are also in there as well. So I go over to that area and just do a skin rolling technique across the top part of the iliac crest. And I get a positive jump sign on the right in the most proximal medial branch of the superior cluneal nerve. And then when I get in there and palpate over that area, I also get a jump sign and I find boggy tenderness on something that many of us were taught looks like a lipoma. But lipomas don't change shape or change size as symptoms wax and wane. Lipomas do exist in this area, and sometimes they can be, an interesting add-on to these. But if the patient notes that there's a size differential when they are symptomatic in that area, that's a neural tunnel that's going on. So this is important. I coached her because she was maybe among the most tender to palpation that I've ever seen in that particular area. And she was jumping all over the table every time I would get into that area. So I told her, I explained to her what I thought was going on, that we had some lingering issues, perhaps with the original disc injury, but that her primary symptoms seemed to be coming from this very small nerve, and that nerve comes from an entirely different area. And that's always nice information for the patient to hear as well, because especially when they've dealt with a lot of pain from a lumbar disc herniation, extrusion, and radiculopathy process, to hear that what they've got is not that rearing its ugly head again, I have typically found to be helpful. Hello to Dr. Nguyen and Dr. Hammonds and Dr. Beaubeard. Nice to see you this morning, sir. Appreciate you dropping in. So the palpation in that area was tender enough that I expected that she was going to be very sore from the work that I was going to do there. And I'm not going to put a cup on that when it's that tender. I'm just going to use my hands and we're just going to titrate the dosage to what she can manage. So I put her in side lying with the affected side up and just used a very broad grip away from the area of affected neurology. And I want you to think about this almost like the way that you can use elastic tape, whether it's K-tape, rock tape, etc., to gather up and lift that area. So you take your hands and you literally shove all of the tissue together and try to lift it up higher, and then have her in sideline to do a movement that would put a mechanical effect on that neurology, theoretically, by doing hip flexion, bringing her knee up towards her chest, and then hip extension, taking her hip back. So we did pass of that, and then retested palpation over that area, and she felt about a 50% reduction in palpatory tenderness there. And then when we sat her up and tried her index posture, in this case, of sitting upright and leaning back into the chair, she reported a 50% improvement. Cool. So I'm pleased with that. Expecting she's going to be sore. I didn't go too far into that. I just coached her into how to do this for homework. And that was the primary way to address the sensitized tissue that was presenting to me in that particular encounter. Now, the way that you guys, especially on the online courses, have seen that I'll organize this is the exercise that I send a patient home with usually targets two things. One is targeting the sensitive tissue in some way to try to calm it down. So we'll borrow from Greg Lehman there of calm shit down and then make shit strong again. So the calming the shit down, we're looking at trying to find what tissue is complaining to us and give it what we think it needs. And in this case, it's better blood flow to the involved or entrapped neurology. So she's got that with her home dermal traction stuff. I also coached her to get 4% over-the-counter lidocaine patches and apply those to calm the nerve down a bit. And greenlit her for using heat over that area as well, which she had found previously to be helpful. She was also taking, as needed, 600 milligrams of ibuprofen 3 times daily, 2 to 3 days a week, and not drinking alcohol with that. Okie doke. Now, exercise-wise, what I want to send her home with is some way of addressing the functional component of this. Now, here's how I line up with the things that I've been taught in regards to other things that can play into cluneal neuralgia. All of you that are watching right now, I want you to take your hands right now and put them on your flank so that you've got fingers in the front and fingers in the back. And I want you to direct your breath using diaphragmatic breathing down into the abdominal region. And as you do that, almost all of you are going to find that it's not all that difficult for you to find your breath in your front fingers, in your abdominal region. You got your belly breathing down. We all kind of learn that through yoga and stuff. But now I want you to try to direct your breath backwards into your back fingers and see if you can find your breath into that area and make those muscles relax and expand and contract. Now, what I think happens, and we talked about this a bit last week, and there's another post on this if you're interested in on the blog here at NeuroCentric Approach. What I think happens, what I visualize happens, and this is just the musings of an old man here, but I think what I'm seeing here is that you've got the transversus abdominis deep is oriented here, and then you've got the internal oblique, more superficial, and then you've got the external oblique, more superficial. And I envision that when a person breathes in like that, it's almost like one of those Chinese finger puzzle trap things that sometimes they play with as kids. And that's expanding and contracting. And I think what happens then is those nerves that go through the abdominal wall, the subcostal, the iliohypogastric, the ilioinguinal, and all of the cluneals, or the superior cluneals, I should say, all of those that jog a little ways between the muscles and then take a turn and go more superficial, and jog a ways and then take a turn and go more superficial. That I think what is probably happening is we're getting a bit of flossing right there at those interface points. So whether it's just, trying to put lipstick on this pig and make it more complex than it needs to be, or not, but this is a bit more of a detailed explanation than just saying breathe into your pain. So then I had the patient put their finger back there in the area where they hurt, and I've seen this work with many, many folks. Put their finger right where they hurt, stack, practice the diaphragmatic breathing, and then direct the breath right into that area of pain. And typically your patients, you'll most likely find that they're able to modulate their pain quite a bit there. This seems simple to us, but the power of this is mostly, I think, psychological. This is agency. This is giving them something that they can do that's simple, low cost, doesn't come out of a bottle. They have an understanding then of the tissues that they're addressing. And now we actually have a way to start to get into the door about the likely reasons why their breathing pattern is disrupted. Remember, Carl Levitt was fond of saying that in musculoskeletal pain, the first domino that falls is disrupted breathing pattern. And when that breathing pattern moves, migrates upwards and becomes apical, then it's my thinking that probably what we're looking at in this area with Main syndrome, with superior cluneal neuralgia, and the other conditions that are part of that Main syndrome, it's likely that what we're seeing is that those particular nerves, the stasis effectively of that extracellular space, is probably leading to a bit of a mechanical interface issue. At least that makes sense to me. And the theory, the applications of the things that I'm doing to try to make it better seem to work. Maybe it's for other reasons, don't know yet, but it makes sense. So I moved her into the supine 3.5-month position per DNS and started working on log rolling. I introduced her to that breathing pattern and had her working on that throughout the day. And I suggested to her that we would use that DNS pattern as our functional fix going forward. And then, because she's depressed, and partly depressed because of the fact that she can't go out and ski, I start to cast her mindset towards getting out on the slopes. So I start to speak to her as an athlete now and less as a patient. And we start to talk about the things that are associated with skiing. I learn more about the type of skiing that she likes to do, the kinds of skis that she's got. Does she ski with her kids or not? Is she looking at, zooming down through slalom gates, or is she an all mountain cruiser? Is she, even at 61, is she going through a terrain park and trying to do something interesting? Is she a powder skier? Is she an ice skier? Does she travel to do her skiing, etc.? So we change the whole vibe of the treatment at the end to cast her gaze going forward into function. to getting her life back to where she wanted it, so that we changed that depressive affect. Changing that depressive affect is key because that's going to change inflammatory cytokine production. That also can help with her sleep, which was also disrupted, partly because of menopausal, perimenopausal or postmenopausal symptoms she was still having. So, and those are places that we can lean into as well for other things in those 4 buckets of epigenetic factors that we can start to lean into: stress, sleep, lifestyle, and diet. Her diet on eval was relatively good, not high carb or anything of the sort. So there we have it. The patient, I saw her, I got an email from her a couple of days later regarding some of the follow-up. And she said candidly, I did not like you very much for about a day. She said, my back was really pissed off. And that was the email contact I had from her. And I followed up and gave her the things that I had neglected to send. I think I had not yet sent her the exercises on the Anteo platform. And so I did not have any idea what to expect from this individual when she showed up in my office a week later. And I fully expected I was going to be doing damage control. And she, once again, she kind of held my feet to the fire for the fact that she hurt when she did. And when she came in after I got through all of that, I said, okay, so how long did those symptoms last? And she said, about 12 hours. Actually, it's about 24 hours. And I was like, okay, well, we talked about that. Good. And I said, okay, and how are you doing now? She's like, I'm much better. And your affect is kind of interesting. And I'm like, okay, that's cool. How much better? She says, I'm at least 65% better. I'm like, all right, what treatment, homework, lidocaine patches, 65% improvement, improved affect for a clinical presentation that's been there for a full year now. Do we have any other work to do on the sensitivity of that neural tract? Yeah, potentially. I think it's probably time to play into the elasticity issues there, and maybe try some tensioners. I think the functional approach with using DNS there is probably going to pay off. And making her aware that her overcorrection of that lumbar lordosis, both in walking and in sitting and with prolonged standing, needs to change, and bring her mindfulness to that, so that when she's out walking, she can maybe address that a bit more by stacking the ribs and maybe even just a little bit of tucking the tail under. Okie doke. So that's what I've got for case study this week. Had some other interesting ones, but we'll hold those for a bit later. With that on the table, you guys on Facebook are welcome to toss any questions out over there. Over here on Zoom, you guys are welcome to weigh in as well. And since I'm talking about Main syndrome and Cluneal neuralgia, we have Mr. Main syndrome himself, Dr. Mark Heller. I fully expect Mark's going to weigh in here and tell me what I've missed on the Main syndrome stuff. How am I doing, Mark?
I love this is a great case. Thank you. I loved it a lot. Um, the only and that aspect of using that front back bracing thing, that was an interesting new piece to me. I've started teaching bracing differently. But I haven't thought of it in relation to Meng syndrome and in relation to the nerves going through the abdomen. That was great. I'm always the question I always have for you is: do you motion palpate and address the thoracolumbar fixation, subluxation, stiffness? Because that's such a common pattern. And what's interesting about with Meng syndrome is the pain is almost never at T11, 12, L1, L2. It's always in the flank or buttock. But the original work of Robert Meng was either manipulation or injections into that thoracolumbar area. And I'm always using both manipulation there and various ways of having the patient self-mobilize the stiff segments there. And I haven't heard you mention that on these Meng cases.
Okay, so specific to this particular patient, she was resistant to manipulation. She had had some negative effects with chiropractors in the past. I find that a lot of the referrals that I get from physicians are those patients. They mention go see a chiropractor, and the patient has some prior encounter with the chiropractor that they found to be negative involving manipulation. So I often wind up getting patients that are sent to me because I do other things that don't involve manipulation. All of that said, Mark, I do motion palpate that area. Hats off to Len Fay. I do manipulate that area. Hats off to Art Walker, who taught me the manipulation that I do in that particular area, which I absolutely adore, and I like it enough that I actually teach it in the in-person courses when we do this, because I usually manipulate that area into what I perceive to be flexion within the parameters of what we think we're doing and what actually happens in that area that at Western States we actually showed once upon a time ain't always the way that we think we are moving the structures that we are getting involved with there. But the way that I will manipulate that is kind of a variation of that, arms crossed like this and doctor stands behind. Often it's their best friend, right, who stands behind them in the gym and gives them a big squeeze. But I'll use a rolled towel into something that's a few inches wide and use that as the contact at the thoracolumbar junction and get them to drop their head, drop their ribs, and try to assume a bit of flexion in that area, because it might be an area that is resistant somewhat to extension, but it typically, to my eye and hand, is resistant in flexion as well. And the flexion gives us a little more room for the involved neurology to be able to move. And that the patient typically reports as being quite well received. And most docs that I show that one have the same reaction that I did when Art Walker first showed that one to me. Art was a big motion palpation guy, and he had even have one of those 2-level stools. Have you seen those, Mark? That that rotates and stuff. So you sit your patient on the high one and the doctor sits on the low one, and does the MPI kind of stuff on that. Let's see. Dr. Glenn Harris is in from Toronto. Thank you for dropping in, Glenn. And I appreciate you including me on your upcoming the disc issue. Glenn, you want to come? You've got a course coming up in March that I'm going to present at. It's a virtual course. I'm going to open up for you to come on video if you want to talk about that. At any rate, MSK Plus, Glenn Harris's organization for continuing education up there in Toronto. They are doing a virtual course in March that is regarding all things DISC. Stu McGill is going to be on there. I'm going to be on there. We've got some other notables. Kathy Dooley is going to be on there as well. So that ought to be a lot of fun. And you guys should check that out for some continuing education available to you online there. Bo, do you have anything to report regarding R2P these days? I think you're still involved there on the board, if memory serves. As is Jeff Arand. Jeff Arand wants to bring an NCA course down to Phoenix. So we're trying to find a date for that, and not too distant future as well. That'll probably be the next one after Seattle, I would imagine, because I want to try to take advantage of the sunny weather in Phoenix before it gets too hot and while it's still pissing rain on me up here in the Pacific Northwest. All right. So
Can I make one more comment? I see lots of patients who, because I have a reputation that I don't do high velocity manipulation much, and I am very fortunate to have studied with the osteopaths. So there's all kinds of mobilization techniques that are much gentler, easier, work on people in pain, work on people who've had bad experiences with manipulation for the thoracolumbar. Just enough said on that. I just think you don't have to pop people to move their joints. So
yeah, agreed. And the grade 4 MOBs, it's something that I employ quite a bit. I'm a bit of a fan of the Mulligan approach as well and all of that, and have utilized that in that regard. Okie doke, folks. This is just about Christmas, y'all. So I hope you are anticipating good times with your family and loved ones, those of you out there, and that are celebrating Christmas. I hope things in the world become a little more peaceful. And until next Saturday at the same time, I wish you the very best. You guys be well, stay curious, go help some people. Cheers.
Thanks, Dr. Snow.
You're welcome.